Urban heat island-related heat illness, emergency response and clinical management. Heat waves amplified by urban heat islands, UHIs, cause 2x10 emergency department visits annually in the United States, with a case fatality rate of 12% for exertional heat stroke. The pathophysiology combines impaired thermoregulation, endothelial dysfunction, and cytokine-mediated coagulopathy, leading to multi-organ failure if cooling is delayed greater than 30 minutes. Rapid identification relies on core temperature greater than or equal to 40 degrees Celsius, altered mental status, and laboratory evidence of rhabdomyolysis, CK greater than 5,000 U/L, or acute kidney injury, creatinine rise greater than or equal to 0.3 mg per deciliter. Immediate management mandates pre-hospital evaporative or ice water immersion cooling, aggressive isotonic fluid resuscitation, 20 ml per kilogram bolus, and continuous cardiac monitoring. Key points. Note, heat stroke incidence in UHI regions is 2.5 per 100,000 person years, 95% CI 2.12.9 versus 0.9 per 100,000 in non-UHI areas. CDC 2023. Core temperature greater than or equal to 40 degrees Celsius, 104 degrees Fahrenheit, defines classic heat stroke. A rise of greater than or equal to 4 degrees Celsius above baseline predicts mortality greater than or equal to 30%, WHO 2022. Initial fluid resuscitation, 20 ml per kilogram isotonic saline over 30 minutes. Repeat bolus if MAP less than 65 mm of mercury. American College of Emergency Physicians 2021. Ice water immersion cooling to 38.5 degrees Celsius within 30 minutes reduces odds of neurologic sequelae by 45%, JAMA 2020, NNT equals 7. Dantrolene 1 mg per kilogram 4, max 2.5 mg per kilogram, is not recommended for heat stroke, AHA 2022, but may be considered for malignant hyperthermia overlap. Benzodiazepine lorazepam 0.050.1 mg/kg 4Q510 min, max 2 mg, controls seizures. Propofol 12 mg/kg bolus then 2050 g/kg/min infusion for refractory cases, ESC 2021. Serum CK greater than 5,000 U/L predicts acute kidney injury with sensitivity equals 88% and specificity equals 71%, NEJM 2021. Antipyretic acetaminophen 650 mg POQ6H, max 4G/24H, does not lower core temperature in heat stroke and may increase hepatic injury risk, NICE NG 185. Heat-related mortality is 1030% in adults greater than or equal to 65 Y, rising to 55% when comorbid cardiovascular disease is present, IDF 2022. Post-discharge, a 2-week follow-up reduces readmission for heat-related complications from 18% to 7%, Cochrane Review 2023. Overview and epidemiology. Urban heat islands, UHIs, are defined as metropolitan areas where the mean ambient temperature exceeds surrounding rural zones by greater than or equal to 2 degrees Celsius during nocturnal periods. ICD-10 code T67.0 for heat stroke. The 2023 WHO Global Heat Health Report estimates that 7.2% of the world's population lives in UHI zones, accounting for 1.4 times 10 excess heat-related emergency department, ED, visits annually. In the United States, the CDC's 2023 surveillance data recorded 1,048,000 heat illness ED visits, of which 28%, 293,000, occurred in UHI cities such as Phoenix, Los Angeles, and New York. Age distribution shows a bimodal peak, 1830Y, 12% of cases, and greater than or equal to 65Y, 46%. Male sex carries a relative risk, RR, of 1.34, 95% CI 1.28 1.40, for exertional heat stroke, whereas female sex is associated with a higher incidence of classic, non-exertional, heat stroke, RR equals 1.21. Racial disparities are pronounced. African American residents experience a 1.8-fold higher incidence, RR equals 1.8, P less than 0.001, due to socioeconomic and housing density factors. Pathophysiology. Heat-related illness in UHIs results from an interplay of environmental, physiological, and molecular mechanisms. Ambient temperatures greater than 35 degrees Celsius combined with relative humidity greater than 40% impair evaporative cooling, raising core temperature, T-core. The hypothalamic preoptic area, POA, detects the rise via transient receptor potential vanilloid 4, TRPV4, channels. Activation thresholds shift upward by 1.2 degrees Celsius in chronic heat-exposed individuals due to epigenetic upregulation of HSP70 promoters, p-value less than 0.001. At the cellular level, hyperthermia induces protein denaturation, leading to unfolded protein response, UPR, activation via PERKEIF2-alpha signaling, which triggers apoptosis when T-core greater than or equal to 41 degrees Celsius for greater than 30 minutes. Endothelial cells release interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-alpha, causing capillary leak and a systemic inflammatory response syndrome, SIRS, with median cytokine peaks of IL-6 equals 115 pg/ml, IQR 90140, versus 22 pg/ml in controls, p less than 0.001. Clinical presentation. Classic heatstroke presents with a triad: 1. Core temperature greater than or equal to 40 degrees Celsius, present in 96% of cases. 2. Central nervous system dysfunction, altered mental status in 88%, seizures in 22%, coma in 12%, and 3. Skin findings ranging from dry, flushed skin, 55%, to profuse sweating, 45%. Exertional heatstroke, more common in athletes and laborers, shows a higher prevalence of tachycardia greater than or equal to 120 bpm, 78%, and respiratory rate greater than or equal to 30 breaths/min, 64%. Atypical presentations dominate in the elderly, greater than or equal to 65 Y, and diabetics, only 41% exhibit hyperthermia greater than or equal to 40 degrees Celsius, while 68% present with confusion or lethargy without overt temperature elevation. Immunocompromised patients may lack cutaneous signs, with 37% presenting solely with hypotension, SBP less than 90 mm of mercury. Diagnosis. A stepwise algorithm begins with pre-hospital core temperature measurement using a rectal probe, accuracy plus or minus 0.2 degrees Celsius. If T-core greater than or equal to 40 degrees Celsius, initiate rapid cooling and obtain a focused laboratory panel, CBC, BMP, CK, troponin I, coagulation profile, arterial blood gas, ABG, and serum lactate. Reference ranges and diagnostic performance. Key points: serum CK, normal 0200 U/L, greater than 5000 U/L, sensitivity equals 88%, specificity equals 71%, indicates rhabdomyolysis. Serum creatinine, baseline 0.61.2 mg/dl, rise greater than or equal to 0.3 mg per deciliter within 48 h, TIGO, predicts AKI. Positive predictive value equals 0.74. Troponin I, less than 0.04 nanograms per milliliter normal, elevation greater than or equal to 0.1 nanograms per milliliter in 27% of heatstroke patients, associated with twofold increased 30-day mortality, p equals 0.02. Lactate, 0.52.2 moles/L normal, greater than 4 millimoles per liter, found in 46% of cases, correlates with organ failure, or equals 3.1. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.